Hey guys, welcome back to Sea to Summit Medicine. This is our third lecture, and today we're going to be going over high altitude medicine. Again, my name is Alexander Hedrick. I'm a fourth year at Rocky Vista University, a part of the Global Medicine track, and I have certifications in advanced wilderness life support and backpacking medicine through the University of Utah, which is where most of this information is coming from. So let's jump right on in to altitude medicine. For those of you in the global medicine department planning on any kind of trips abroad, this can be super applicable to you, especially if you're going into any parts of Asia, like the Himalayas, where you're going to be dealing with altitude and altitude sickness, especially in any kind of recreational users who are coming in to the area from sea level or lower elevation. So we're going to be reviewing high altitude medicine, which includes the physiology and physics of increased elevation on the body, talking about acute mountain sickness, high altitude cerebral edema, and high altitude pulmonary edema, which are pretty much the three mainstays of altitude medicine. We're also talking about risks, prevention, and treatment. So let's jump into the physics of it. So we kind of briefly went over this idea when we were talking about dive medicine and talking about atmospheric pressure. So a good way to think about it is if there is a column directly above your head, all of the air molecules within that column basically has a certain amount of weight, and however much weight is on your head at whatever altitude you're at, that is your atmospheric pressure. So that's the quick and easy version of it. Basically, the gravitational force coming down at whatever elevation you're at determines how much of these partial pressures of these air molecules are held within that space. As you increase in elevation, getting higher and higher, you have decreased amount of gravitational force on that column above your head. That is decreasing the amount of air molecules within that column in your breathing space. So basically, you can think of it as the reverse of diving. Diving, we were talking about as you go down, you're increasing the pressure around you, which compresses the air molecules around you, causing more and more to seep into your tissues. Now, the reverse would be as you're getting higher, you're decreasing that pressure around you. You're decreasing the amount of partial pressure of gases that is permeating your tissues. And as you increase in this level, you can get uh, dangerously low pressures of these molecules. So hypoxemia, hypercapnia, and so on. But hypoxemia being the big mainstay we're talking about. So altitude illness is pretty rare at elevations below 2,000 meters or 6,500 feet, but it's not uncommon. Basically, go ahead and have it in your head that anyone coming from sea level to any elevation can start getting these kind of symptoms, especially if they are of gross body habitus, have pre-existing health conditions, especially respiratory conditions, or just have general low health maintenance. They can start getting these symptoms at even lower altitudes. Basically, we need the pressure around us to be able to push oxygen into our bloodstream, basically creating enough pressure that there is enough partial pressures of these molecules that we can breathe in and get circulating in our body. Um, and the idea is as we're increasing in altitude, decreasing the amount of these partial pressures, um, and basically you have decreased amount of oxygen you're able to breathe in, but you're still using your oxygen stores that you have on board. So you're creating more carbon dioxide in your body. What your body does is it tries to increase the levels of your oxygen, decrease the levels of your carbon dioxide by hyperventilating, and that's basically how your body's trying to acclimate. So this is just kind of a quick little map of some of the peaks in the world and where individuals start getting these kind of symptoms. So high altitude is again starting anywhere 2,000 meters and above. It can be slightly lower. Commercial aircraft are actually pressurized to an altitude equivalent of 1,500 meters to 2,500 meters. So again, they're pressurized to that level because that's still low risk of having altitude sickness. But if you ever get headaches on planes or anything like that, it's because the pressure is so much lower. Um, then, as you're ascending altitude, somewhere between 2,000, 3,000 meters, you can start getting acute mountain sickness and high altitude cerebral edema. We'll talk about those here in a bit. Um, you can start getting psychomotor impairment as you're getting above 3,000 meters. Above 4,000, you're starting to decrease your learning, spatial memory. That's considered very high altitude. Memory retrieval starts getting impaired around 6,000 meters. 7,000 meters, if you were taking an MRI, you could start seeing white matter hyperintensities, cortical atrophy above 7,000 meters. So this is kind of you're talking more about jet pilots, those climbing Everest and that sort of thing. And then as you get extremely high, so at the level of around Everest, above 8,000 meters, you can start hallucinating, get hypoxemic injury, and then you can black out and eventually die as well. So this is all just kind of give you an overview of the breadth that altitude medicine considers, because it basically considers all the way from 2,000 meters up to 8,000, which is Everest climbers. We're not really going to go into talking about uh, military jet and that sort of aerospace medicine today. Okay, so we already started talking about this, but basically, when you go from low altitude to high altitude, your body starts trying to acclimate because you're not getting enough partial pressure of oxygen. The body is building up carbon dioxide. It is unhappy, and so it's decided, okay, we're going to start the methods for acclimating. So, when you don't have enough pressure to push oxygen into the bloodstream, but you're still using a lot of muscles. So if you're hiking up a mountain at high altitude, you're not getting enough oxygen, but you're still using your oxygen stores, creating a bunch of carbon dioxide in your system. That's telling your body, okay, wait a second, we have too much carbon dioxide on board. Where's the oxygen? It stimulates your carotid bodies, which then stimulate the respiratory center of your brain, saying, hey, start breathing more. You increase your ventilation there, then, which you're blowing off CO2, so you're decreasing the amount of carbon dioxide on board. You're also increasing the amount of partial pressure of oxygen you're capturing, and that is the acclimatization. I can't say that word for the life of me. Acclimatization process. Okay, so removal of that CO2 as you're hyperventilating, you're breathing off more and more of that CO2 can cause alkalosis of blood, so increasing the pH of your blood because carbon dioxide is acidic. And that actually can decrease the respiratory drive. So you get this counteractive opposition of of increasing the respiratory drive once you start blowing off enough CO2. The kidneys then kick in, saying, "Hey, we're going to help out too," and start secreting more of your bicarb, which has a higher pH. So as you're peeing more of that off, you're decreasing the amount of alkalosis in the blood. So you're getting renal compensation for your respiratory alkalosis, and then kind of brings you back to a baseline pH where your system can rev up that respiratory drive again and continue your acclimatization. Eventually, once you have this increased respiratory drive that kind of keeps you stable, um, your body starts saying, hey, we're a little bit hypoxic. Let's start making new red blood cells so we can capture more oxygen from the atmosphere. So even though there's a lower partial pressure of oxygen surrounding you, if you have more red blood cells that can catch more of the oxygen as it passes the alveoli and you get that gas diffusion, then you can increase your body's capture and store of oxygen and basically finally acclimate to whatever level you're at. Okay, so that's the basics for acclimatization. So what happens when you're on a big hiking trip, you keep going higher and higher, you don't give your body a chance to acclimate? What are some of the complications? What goes wrong? So one goes from low to high altitude too quickly without acclimatizing. Complication can ensue from edema accumulation. So basically, this is all surrounding edema, and we'll kind of go through the basics of that. But basically, you should know there are three categories to high altitude medicine. The first is acute mountain sickness. You are going to get this no matter what if you're getting altitude sickness before you get either the other two levels. So you can think of these in tiers of levels. You're always going to get number one. You're always going to get acute mountain sickness before you get high altitude cerebral edema or high altitude pulmonary edema. These two do not have to happen in series. They can either occur one or the other with acute mountain sickness. Sometimes you'll only get acute mountain sickness. Sometimes you'll get two of them, or you'll get all three of them. So we're going to start with acute mountain sickness since that's what everybody gets. The clinical diagnosis is through your history, talking to a hiker or someone who's come up from a lower altitude. So that's the first thing you should think about is, hey, I took a plane ride from LA today. I'm in the mountains of Utah suddenly, and climbing at higher altitudes. Other history that would kind of tell you is that they went up in altitude really quickly through a climb. So if they're hiking Kilimanjaro, hiking in the volcanoes in Ecuador, something like that, where they go from the bottom to the top very quickly. Also, when they have not been drinking a lot of fluids and then they've been hiking really hard for several hours going straight uphill. All of these in their history, you're talking to them would kind of indicate, okay, this is acute mountain sickness more than anything else. So some of the symptoms they'll be presenting with, the most common is headache. So you're almost always going to have headache in these individuals. And this can even occur on airplanes, like we were talking earlier, for people who fly infrequently and are suddenly getting symptoms of acute mountain sickness. Other symptoms you can start getting is some dizziness, lightheadedness, fatigue and weakness, which again, if they've been hiking really hard, you can't really use that as diagnostic criteria. They can be getting nausea, vomiting, can look anorexic, or they can be have insomnia at base camp. So the risk factors are rapid, high ascent, prior history, and also obesity. All of these things can kind of contribute to this. So high altitude or acute mountain sickness can affect tourists around 8,000 feet or above. But again, if someone's coming straight from sea level to higher altitudes, you can get it even lower. Okay, so let's talk about the next step. So someone who has acute mountain sickness, just carries on happily and keeps going, climbing higher and higher. What are the other two things that can happen to them? Well, the first one would be high altitude cerebral edema. So this is a very dangerous thing that you want to keep an eye out in for anybody who showed symptoms of acute mountain sickness, or if you and your party are climbing to quite high altitudes. So let's just think through this. So as the hypoxia continues, fluid continues to accumulate in the extravascular space, causing cerebral edema. The incidence is about 0.5 to 1% in cases of acute mountain sickness progressing to high altitude cerebral edema. And it usually occurs over 1 to 3 days from the headache that you get with acute mountain sickness all the way to causing the person to pass out and even falling into a coma. It usually is diagnosed as severe acute mountain sickness with neurologic findings. So having ataxia, altered mental status, severe lack of energy and weakness, and altered levels of consciousness, semi-consciousness. Severe lassitude, which is physical or mental weariness or lack of energy, as we were saying, is kind of the mainstays. Again, how do you differentiate this from just being super tired from their hike? So you have to really just be careful and aware and talk to them and get a proper history. So something to kind of cue you in is a hiker, a climber in your group who has a headache and that sort of thing, just wants to stay in their tent for the rest of the day, not do anything. That's super concerning, and you should instead think about starting to get them to climb down, because as this progresses, again, you can go all the way from headache to all the way to coma, and this can be extremely deadly. So you want to be on top of it. I was actually just talking to some personnel here at the local park near Dinosaur Land in Utah, and their Boy Scout troop actually had one of their cousins come in from sea level, fly in to do hiking trip in Flaming Gorge, and ended up dying on the trip because of high altitude cerebral edema. Kid was just super tired, didn't want to do anything, stayed in his tent, and they checked on him another day, and he was dead in his tent. So this is really concerning, and you need to make sure to be aware of it in your group. This is just kind of going over uh, the cerebral edema portion. So you can also get increased amounts of edema around the brain, causing herniation. So you guys have probably gone over this in your neuro lectures, being subfalcine herniations, transtentorial herniations, and even tonsillar herniations. The latter being the one that can actually shut down your respiratory drive, and you want to be extremely careful. Okay, so the third and final phase, well, I say phase, but really it can happen with or without high altitude cerebral edema, is high altitude pulmonary edema. So basically, we talked just now about edema surrounding the brain. This is edema surrounding and filling up the alveoli of the lungs. It evolves over 2 to 4 days after ascent to altitude. Again, you're going to get acute mountain sickness and have those symptoms before you have high altitude pulmonary edema symptoms. And the diagnosis requires basically two findings. One is dyspnea at rest, so they can't quite catch their breath even though they haven't moved for 30 minutes. They're coughing quite a bit. The cough can have with or without pink frothy sputum coming up, and then having a lot of chest tightness, congestion, and that sort of stuff. So on physical exam, if you have a stethoscope with you, you may find crackles, wheezing, and at least one lung field. You may see some central cyanosis, and then tachypnea and tachycardia as well on physical exam. So basically, you're getting edema in the lung spaces, so either surrounding the lung or actually within the alveoli, filling up the alveoli and totally obstructing areas of gas exchange. So they are not only not able to acclimate, they're not able to get their CO2 off or oxygen in. So this can be quite deadly, and this is something you want to really watch out for, and it can be scary. Um, so some risk factors for all three of these things. The rate of ascent is the big one. Say someone's taking a quick jaunt up Kilimanjaro or Machu Picchu. I've done the Machu Picchu. I actually got severe acute mountain sickness from quickly running up Machu Picchu. I'd done a 5-day trek across the Salcantay Mountains, and then quickly went up Machu Picchu right after, and it just destroyed me, and it was super tough. Um, so that's something you want to think about is very, very quick trips with large elevation gains. Your sleeping altitude can really affect high altitude cerebral edema and pulmonary edema. And it can, especially if the hiker camper is alone in their tent, and these symptoms can be progressing without anybody noticing and can be quite deadly quite quickly. Exertion before acclimatization. So basically, you don't give your body enough time. You start exerting it quite a bit, so you get buildup of your CO2 stores on the bottom, your in the body, and then you are not able to properly get enough oxygen in the system, so you're not giving your body a chance to acclimate. Alcohol or sedatives can also be a big risk factor for forming any of these conditions because they inhibit the respiratory drive. And so inhibited respiratory drive, you're again preventing acclimatization, and then you're further increasing your CO2 stores on the body, not getting enough oxygen. Eventually, and this is also going to cause your blood to turn acidic, which can further induce cerebral edema. Because again, the way that you acclimate is you cause hyperventilation by inducing the respiratory drive, which then causes the blood to get alkalotic. Kidneys then kick in and all that. But basically, if you're inhibiting the respiratory drive, you're not going to be hyperventilating. You're going to get further buildup of that CO2 in the body, and just going to turn your blood acidic, which can cause further cerebral edema and pulmonary edema. Dehydration is a big factor in forming these conditions. And then if you have any kind of pre-existing conditions, including sleep apnea or COPD, any lung conditions that are going to decrease your ability to gas exchange. Asthma, funny enough, doesn't increase your risk. But if you do have cold air or hiking the mountains or anything, or there's a lot of pollen around, it can induce asthma attacks. So make sure you have your inhaler on board. Um, Anemia and pregnancy do not increase the risk, surprisingly. Um, but do keep in mind that pregnancy does make you hypercoagulable. So, women who are pregnant who are suddenly having chest tightness, a shortness of breathing, and stuff, even if they do have the history of high altitude risk factors, they also have the risk factor of pulmonary embolism. And then something to note is youth and physical conditioning do not mitigate your risk. It doesn't matter if you're young, fit, if you are hiking too quickly, it does not mitigate your risk. It does not allow you to acclimate faster. So that is something to know. Now, if you're doing physical conditioning like a lot of bikers do, in which they put themselves in low oxygen environments, even if they're at sea level, to train so that they can build up the amount of red blood cells they have on board for oxygen capture, then that type of conditioning can mitigate your risk. So that's just something to keep in mind. Okay, so knowing the risk factors, let's talk about preventing these things from happening. The best way to prevent symptoms from occurring is slowly acclimating while you gradually ascend in altitude. Um, so again, we said above 2,000 meters is kind of the general threshold for starting to develop symptoms. Spending 2 to 3 nights at 2,500 to 3,000 meters is what can really help you acclimate to an area before starting an ascent. Make sure you avoid increases greater than 600 meters in sleeping altitude. That really does put you at risk for high altitude cerebral edema or pulmonary edema if you do increases greater than 600 meters. Spending one extra night of acclimatization every 300 to 900 meters of gain can also really make sure that you prevent any of those dire consequences. Making sure you hydrate is key, but make sure you also don't overdo it, overhydrate, because then you can dilute out your electrolytes and cause quite a bit of muscle cramping. So wanting to be careful of that. Um, you also want to avoid overexertion, especially before you acclimate. So again, if you are fighting against your body by creating more body CO2 buildup through heavy exertion before your body is acclimated, you're not giving it the chance to properly acclimate, and you will start developing symptoms. So a lot of people talk about medications that you can use to if you're going to high altitude, but you need to know that the medications are symptom management. They are not management of the actual underlying condition. So medications are not a substitute for gradual ascent. Absolutely not. Um, Acetazolamide or Dimox is kind of the mainstay of treatments for people going to high altitude and have propensity for developing high altitude illness. The only time it's actually appropriate to use these medications with patients is if you know they're going to around that 2,500 to 3,000 meter range. They've had altitude sickness before and they want to prevent those symptoms, but they are planning to acclimate before going higher in altitude. They are not planning to use this as their mainstay prevention of altitude sickness as they're climbing higher. So this is only if they're planning to be in that 2,000 range and they want to prevent the headache and that sort of stuff. The acetazolamide, again, is a carbonic anhydrase inhibitor. It reduces bicarb resorption, causing metabolic acidosis. So again, it's preventing the headaches and stuff that form because of the alkalosis in your blood as you hyperventilate and breathe off that CO2. So basically, it preemptively starts the renal contribution to offsetting the alkalosis in the blood from breathing off the CO2. It does have some side effects and can cause paresthesis. It can cause polyuria, sulfa allergies. You don't want to take this stuff. So that's stuff to kind of be aware of. The other treatment is dexamethasone, which is a steroid. You can begin that the day of your ascent and continue 2 to 3 days once the maximum altitude is reached, but no more than a 7-day period. Again, it's not a substitute for gradual ascent, but it does help with any irritation of dural membranes and that sort of stuff. It can just basically help you um, mitigate some of the symptoms from altitude sickness. You do not want to give this to diabetic patients again, because that's going to mess with their blood glucose, and then you're going to have a patient in the high altitude area also with ketoacidosis. So yeah, bad. Don't do that. Um, Some other things that people commonly tell you, a high carb diet, it actually doesn't reduce your risk. So just know that high carbs are not going to mitigate it. For those of you who have been Central America, coca tea, which is basically the cocaine leaf, it's but instead used to brew tea, is basically an analgesic, but it doesn't really have much benefit, and it doesn't actually prevent altitude sickness from occurring. It's just, a common custom to use there. So you may get a little of analgesic from it, but other than that, it doesn't really help. Um, Also, something to note is the acetazolamide or the Diamox actually prevents instant hydration of CO2 on the tongue, which means any carbonated beverages might taste really funky if you're taking the acetazolamide. So that's really interesting to think about. Okay, so we've gone over what happens at high altitudes and risk factors and prevention. Now let's talk about treatment. Treatment is descend, descend, descend. Your mainstay for anyone who is having symptoms is to get them off the mountain, get them at a decreased altitude as quickly as you possibly can. That is the only way you're going to increase their partial pressure of oxygen other than putting an oxygen mask on them, which most people don't carry oxygen tanks with them. What people do carry nowadays is those little spray bottles, which have a certain amount of oxygen in it and oxygenated breaths. That can actually help stabilize someone. And then immediately after you use that, get them down to a lower altitude. So that's just kind of something to keep in mind. Um, you want to descend 300 to 1,000 meters from where they started having symptoms at, especially if it's high altitude cerebral edema or pulmonary edema, you want to descend even further than that. But descending 300 to 1,000 meters can kind of do it for the acute mountain sickness. Um, but you may say to yourself, hey, it's a little headache. Do I really need to descend? The answer is you can kind of feel it out. If someone has a little bit of a headache, is breathing a little hard, and you stop, make camp for a bit, have some lunch, and then a couple hours later, they're doing totally fine, they're okay to start reascending again. But if their symptoms are persisting, then you want to descend, okay? Um, you can give analgesics for the headache, um, but again, this may mask symptoms and say, hey, they're really not okay. They don't need to keep going higher. We need to stop here. You also don't want to camp overnight where the person was having the acute mountain sickness symptoms. So they were having either the headache or trouble breathing or any of that. You want to go down to a lower elevation to camp. We talked about the acetazolamide and the dexamethasone. Again, that's only symptom treatment. The O2 therapy is, again, those canisters you can carry with you, give you a burst of oxygen, and basically increase the partial pressure of oxygen around your mouth, so you're increasing gas exchange. But again, it doesn't really provide a long-term solution for the underlying condition. One thing you can use for people who cannot descent is not possible, is the Gamma bag. So this is basically a hyperbaric chamber that's portable, that you can blow up with uh, oxygen, basically increase the partial pressure of oxygen just within the chamber. Um, and this may be life-saving only if descent is not possible, but it should not delay descent. If you can get them on your back, or your group of friends can carry them down, you need to descend. That's going to be your primary life-saving treatment, okay? So with that kind of covers high altitude medicine. Again, my name is Alexander Hetrick, Rocky Vista University. You can contact me through email, or if you have any updates to the information. I mean, this is an evolving field. If there's any new information, there's any corrections you want to leave, or personal experiences, please put them in the comments below. Otherwise, please join us for our last lecture on avalanche medicine.